Yeah, good evening, everyone. I want to welcome you to our presentation. We'll start in a couple of moments just to allow our other guests to join. Dr. Ahmed, we're looking forward to the presentation tonight. It's certainly very topical and timely.
Yeah. Oh, I'm looking forward to it.
Yeah. Okay, people are starting to join in, but we'll give it another minute or so. Right, well, look, to respect people's time, we'll get things going here. So first, I'd like to welcome everyone tonight. My name is Chris Malloy. I'm a senior advisor at TMFD Financial, and I'd like to start by thanking you for joining us for this evening's presentation titled AI in Practice, How to Assess Innovation Before Adopting It. And in a moment, I'll present our speaker, Dr. Ahmed. But first, I'd like to briefly introduce TMFD Financial. Our goal is to simply make the lives of our dentists simpler by combining a variety of services under one roof, from tax, investment, insurance, and other financial planning matters you may have. In our experience, we found that providing a one-stop shop for financial solutions gives clients the comfort of knowing that all aspects of their financial affairs are synchronized. And the result is simplicity, peace of mind, and confidence in your financial decisions. For those new to TMFD, I wanted to mention a couple of offerings that might be of interest. So for our practice owners, we have a dental practice assessment and financial review. And this process highlights the financial health of your practice. It identifies areas of excellence and areas for improvement, as well as an estimated value of the practice. This is a service we offer to all existing clients, so if this is of interest, feel free to contact us. TMFD also helps dentists through the buying and selling process. So for buyers, for associates, this includes a review of the practice cash flow and loan projection payments. And for sellers, it includes tax planning as well as identifying areas of strength and potential areas of concern. More details about both offerings will be provided following this presentation. But at this point, I'd like to hand things over to my colleague, Jake Giesler, for a few housekeeping items.
Thanks so much, Chris. And good evening, everyone, and welcome to the TMFD Dental Academy. Thank you so much for joining us this evening. As Chris mentioned, my name is Jake Giesler. I'm a financial advisor here with TMFD Financial, and I'll be running the technology in the background this evening. But before we get started, I just want to take a moment to run through a few housekeeping items. This webinar is scheduled to go to about 8 p.m., and if you have any questions for Dr. Ahmed during the presentation, please ask them in the Q&A section at the bottom of your screen, and they will be answered at the end of the presentation. If you have any questions for me behind the scenes or something you'd just like to comment on, please feel free to send a chat in the chat box. Lastly, CE credits will be sent out within 2 weeks, no later than April 8th, and we encourage you to register for our TMFD Dental Academy mailing list so you can stay up to date with all of our future webinars. And that's all the housekeeping items I have for today. So Chris, I'll throw it back to you.
Awesome. Thanks, Jake. All right, so now I'm very pleased and excited to introduce our speaker, Dr. Ahmed. Dr. Ahmed practiced general dentistry in Canada for 9 years before specializing in oral and maxillofacial radiology at Stony Brook School of Dental Medicine. Dr. Ahmed has focused his research on AI applications for detecting carotid calcifications on CBCT images. His career continues to be defined by his enthusiasm for integrating artificial intelligence into oral healthcare. He currently practices as an oral maxillofacial radiologist at his own private practice and with beam readers. So in today's presentation, Dr. Ahmed explains the basic concept of how AI learns versus how it presents its conclusions. as well as practical questions to consider when using AI for patient care. So Dr. Ahmed, from all of us here at TMFD, we'd like to thank you for your participation, and I'll turn things over to you.
Oh, thanks for that introduction, Chris. Yeah, good evening, everyone. Thanks for joining us. I know it's not the first thing you want to do when you get home from work, but hopefully we have an interesting topic for you from a different perspective today. So before I get started, a little introduction about myself. So I graduated dentistry initially in Egypt in 2007. And following graduation, I enrolled in a one-year GPR where I practiced. And then I decided to return to Canada, where I grew up, and I joined the IDDP program at the University of Manitoba, where I spent 2 wonderful years. And then after graduation, I spent, like Chris was saying, about 9 years in general dentistry. And I focused a lot of my continuing education on occlusion through Spear, Pankey, Dawson, a little bit of orthodontics through the Rondeau courses, implants through Timax. And I really started to enjoy sort of a well-rounded global patient care private practice. And then COVID hit, and I got stuck at home like all of us for about 3 months. And it just so happened at the time that my next door neighbor was a radiology resident at U of T. And so we spent a lot of time together during the lockdown, and we got to talk about radiology and how it was primarily an academic specialty. And with the advent of lower radiation cone beam CTs and newer machines, it sort of shifted into private practice. And it really interested me that it's sort of one of the specialties where you can maintain being a general dentist and have a whole new diagnostic skill set. And so I decided to apply. I was lucky enough to have my choice of schools, and I chose Stony Brook University. And it's one of the few schools that allows you to choose whether you do a master's degree or not. And so during my 2 years, I worked with a biomedical engineering team at Stony Brook who were just brilliant. And we developed an AI model to detect and segment intra and extracranial carotid calcifications, and then to extract features from them and correlate them with indicators of cardiovascular disease to create a prediction tool. And that was my sort of introduction into AI. And ever since then, it's sort of the golden word of our decade. And it's really interested me on how AI is developed and how we view it as healthcare professionals. And then following my graduation, I opened my private practice, Starling Oral Radiology in Toronto, and I also serve New York. And I work with a lot of dentists across Canada and the US. And I still maintain a general dental practice 1 or 2 days a week as an associate. And so I go to a lot of these, conferences and shows, and I'm constantly bombarded by all these sales reps with new AI models. And I think to myself, I've been lucky enough to be involved in the AI world. And just like any industry, while there are a lot of good AI models, there are some gimmicks thrown in there. And because I've had the experience of working with good teams, I can sort of figure that out for myself. And I realized that a lot of my dental colleagues, they're like, well, we don't know. It just looks good. And so that's what inspired this talk today, sort of to, instead of just advertising AI, to sort of go through a brief history of everything that goes into developing an AI model up to the point of, well, how can I evaluate? Is this a good model? Is this a bad model? Is this suitable for my patient care? So today we'll sort of we'll talk a little bit about AI, some of the terminology that you'll hear. We'll look at how models are trained, how we train them, the different methods of training models, and why that matters. We'll look at some of the common problems that we utilize AI to solve in dentistry, the type of networks we use and why we use those networks. We'll look at some of the current uses of AI. We'll look at how to critically evaluate these AI models. And then if you as a clinician or as an office owner, or if you're an associate, and you're going to adopt an AI model, are you just going to sort of start using it, or what are the things that you should keep in mind before you use it? So before we get started, I'll pass this back to Chris, and we'll take a little poll and see how many practitioners currently use AI within their practice, whether it's in an individual area like imaging, documentation, if you use it in more than one, or if none of you, or you don't use AI at all within your practice. Chris?
Yeah. There we go.
Give a moment here to let the results trickle in.
Well, I think that is the final poll, not the first poll.
Oh, my apologies. They were swapped here. Let me launch this poll then here.
Yeah, there you go.
Let the correct results trickle in here. – 65% don't use AI in their practice.
Yeah, I would say that's about standard. All right.
But that number must be growing.
Well, yeah, it's a very new phenomenon, and there's still a lot of unease towards it, and people need to understand it. All right. So, yeah, I'll get started. So, we define artificial intelligence as systems or machines that are capable of performing tasks that typically require human intelligence. Now, as humans, we have two primary modes of learning. We have declarative knowledge, which is memorization and accumulation of facts. And then we have imperative knowledge, generalization, where we extract new facts from old facts. So for us to define a system as an AI system, it has to have one or more of these five features. So we have learning, the ability to acquire information, and rules to use that information. If it can use an established set of rules to reach an approximate or definitive conclusion, it has reasoning. If it can formulate a sequence of actions to reach a desired objective, it can problem solve. Perception, interpreting sensory input such as recognizing objects. This is a dog, this is a house, this is an animal, this is Denton. And language, to be able to process and generate human language naturally so we can understand the model itself. Now, when we say AI to the common public, the first thing that usually comes to mind is something similar to, iRobot or Terminator. And we define that as artificial general intelligence, or AGI. And this is a theoretical stage where a machine possesses the ability to understand and apply knowledge across any generalized task at the same cognitive level as a human being. Now, early on, developers thought that AI could fully replicate comprehensive human intelligence. And quickly they understood that human cognition is so complex, and that wasn't a very easy feat. And so the shift focused to artificial narrow intelligence, or weak AI. And these are systems that are highly specialized to perform single tasks or very narrow range of tasks. So think of playing chess, facial recognition, movie recommendations on your Netflix. Now, all AI that we utilize today is narrow AI or weak AI. Now, we can take this weak AI and we can apply it in different ways or different mediums. So we have physical AIs, and these are robots. Like when you go to a conference and you see those robotic arms that place implants. And then we have virtual AI, and these are software algorithms that support clinical decision making. They reduce administrative burdens, and this is the primary type of AI that we utilize today. Now, the American Medical Association deliberately uses the term augmented intelligence rather than artificial intelligence. And this is to emphasize that these technologies are designed to sort of enhance and support human clinical decision-making and not replace the physician. And it's very key, and we'll see why throughout this presentation, to adopt this assistive mindset because it keeps the human element at the center of patient care. And it allows us to utilize this technology to reduce our burnout, reduce administrative burdens, and improve our diagnostic accuracy. And we'll see how we can quickly rely on it and start losing our skills. All right, so let's take a look at how models learn. So there are a few ways of how we can train models, and they're not all equal. So one of the very common models is a top-down model or a knowledge-based model. And think of this as a rulebook approach. So this is where a human expert writes a strict rulebook for the computer to follow. Okay, so this system relies on explicit logic being programmed by a person. So a lot of if-thens. So if we take a look at an example, we have a patient that comes in and they have shade A3. So if they have a shade A3 and we apply a bleaching protocol, then the output is A1. And we can see that we have to go back and say, well, if we're going to input a shade 3 and the bleaching protocol is Philips Zoom for 15 minutes, then the output is A1. And then you'd have to go back and say, well, if the input shade is A3 and the bleaching protocol is Philips Zoom for 45 minutes, then the output is A1. And you can see how it quickly gets very complex and how we have to account for so many variables. Because as humans, we don't need to think that if I'm going to apply this whitening for a longer period of time, the shade is going to get whiter. We know that, it's in our subconscious. But we have to explicitly tell a model how to do that. And so you can see the limitation in that acquiring all this knowledge and coding it is a major bottleneck. It takes significant time and effort. And so knowledge-based models have sort of been phased out for AI. And now we have bottom-up and data-driven models. And think of these as an experience approach. Okay, so in data-driven models, computer algorithms write their own rulebook by studying the past experiences of human beings. Now, this is also termed machine learning, and this is a common term that you'll hear. Now, think of an example, and we'll come back to this example several times, that we're trying to teach a model how to detect interproximal decay on bite wings. So in a top-down approach, we would say, well, if you have a triangular area of low density that is below the contact with the base outside and the point towards the center, that looks like a cavity. In a data-driven model, we don't really do that. What we do is we use labeled data. So we get a series of bite wings, and we're going to say, this is a cavity, this is a cavity, this is a healthy tooth. And we're going to feed all these to the model. And what it's going to do is through statistical analysis and pattern recognition, it's going to start understanding that, oh, if I have an area of lower density right below the contact, that's where all of these are. And they're all labeled cavities. So this is a cavity. They're all labeled interproximal decay. So this must be the location. And you can see why these models become very popular because simply right now we have a lot of digital data. We've accumulated it over the past. It's within our systems. And so it saves us a lot of time and allows these models to be trained very quickly and figure out these patterns on their own. And so within machine learning, we're presenting a significant amount of data. And we can present this data in multiple ways. And so we have supervised learning. So supervised learning, we use structured labeled data, very similar to the example that we were talking about decay. So with supervised learning, we have our input, which is labeled data stating that this is decay. And we know our output, which is we want the model to understand what decay is. And we try to increase our model's predictive accuracy. So this happens through regression classification, so pattern recognition, basically. Alternatively, we have unsupervised learning. So unsupervised learning, we give it unstructured, unlabeled data, and the machine or the model can start to recognize hidden patterns entirely on its own. And so in this scenario, we have various inputs, but we don't really know the outputs. And sometimes we don't really know the inputs. So if we give it a model 10,000 bite wings, and some of them include interproximal decay. Some of them include, periapical lesions or bone loss. What it's going to do is through association and clustering, it's going to say, well, these all are similar together. These all are similar together. And it's going to start to find the patterns on its own. But what it also might do is find a completely different cluster. And it's going to say, oh, well, these all are missing teeth. Now, while this isn't very valuable in bite wings, when we come to significant pathologies or systemic diseases, models can now start finding characteristics that were imperceptible to the human eye and say, oh, well, you know what? All these people that have hyperparathyroidism have this specific bone texture or this specific loss at this specific time. And so we get very valuable input from them. And then we have sort of a mix between both of them, and that's semi-supervised learning. Now, this was a technique designed to solve a common problem in AI, and that labeling data is time-consuming and expensive, but raw data is everywhere. It's in our offices all the time. And so while a supervised learning requires fully labeled data set, semi-supervised learning uses a small amount of labeled data combined with a large amount of unlabeled data. And the core idea here is that the model will use the small labeled portion to learn the basic rules, and then use the unlabeled portion to understand the underlying structure and distribution within the data. Now, between these three, there isn't one that's better than the other, but they all have their own individual uses, and we'll see that coming up. So let's take a look at some of the problems that we encounter in dentistry that we want to solve with AI, and some of the networks that we use, the machine learning networks, and how we train them. So currently, radiology accounts for about 75% of all authorized medical devices by the FDA. And so that's a significant portion. And convolutional neural networks are the undisputed champions of image processing. Okay, this is the ultimate pattern recognition engine, and this is primarily what I use. So if we imagine we're trying to teach a first-year dental student how to read a PA, okay, we're not just going to tell them, hey, look at this whole gray square and guess. We're going to teach them to look for specific visual building blocks. You're going to look at that little stark white of the enamel. Look at this continuous gray line. That's the lamina dura. Look at this dark line right below it. That's the PDL space. Look at the trabecular bone pattern. This is what's normal. And a convolutional neural network learns to read an image in exactly the same way. It breaks this complex radiograph down into simpler visual features and then builds up to a diagnosis. Now, I'm not going to get too technical into it, but we'll just explain briefly this example. For example, we're trying to teach a model how to detect periapical lesion. So we have our input data. We're going to give structured labeled data. So we have all our periapical lesions labeled, and the pixels are chosen. So our input data here is a set of pixels with shades of gray that are represented by numerical values. And so what the model will do is it's going to go to this area of pixels that we chose, and it's going to apply a convolution. And a convolution is a fancy word for a mathematical formula. Now, that mathematical formula might be ×2, or it might be, the sine wave of I don't know what. Some of them get really complex, and they're usually very complex. And so when it applies that convolution, what it does is that mathematical formula enhances certain features. So enhances certain features like edges, like curves, structural boundaries, texture, okay? And so convolution is a feature extraction stage. Now, while one filter or one convolution might specifically teach the model how to recognize the curved shape of the root apex, another one might learn, the texture of healthy trabecular bone, and then the other one will look at the darkness or the low density of the periapical radiolucency. And it does this millions and millions of times with millions of different convolutions and features. And so it keeps on extracting all these features. And then it reaches a pooling stage. And so the pooling stage starts to isolate the most prominent features. So it goes to this periapical lesion and it says, well, you know what? All these lesions, I had normal bone, which is, let's say, for example, the pixel value in terms of numbers, 10,000, and then all of a sudden it goes to like 0. And so all of them have this feature. This is an important feature. I need to keep it. All these areas where I have this drop, they're all around the apex of a tooth. So the location is very important. So it starts to see patterns, and it isolates that feature. And then it discards all the redundant pixels, the background pixels that have no value. It's like, oh, this one has an amalgam, this one doesn't have an amalgam. That doesn't make a difference for this lesion. And then it gets to the output layer. So what this layer does, it's very simple algorithmic classification, statistical probability. It's going to say, weigh all the evidences, and then give you a classification and say, this is a healthy tooth, this is a periapical lesion. And you can see that convolutional neural networks don't memorize what a diseased tooth looks like. Instead, it mathematically learns the hierarchical values of the anatomy of a periapical lesion, and then it allows it to accurately classify a new unseen radiograph based on those patterns that it learned. And these are very powerful models, and we can teach them to do really, really marvelous things. Now, another problem that we might have, and we can solve it with two different ways. So if we try to classify, the difference between acute and chronic periodontitis. You have a patient, you have a lot of information on this patient, and you want an AI model to classify them for you. And so we can do that in two different ways. We can do that with support vector machines, for example. Now, this uses supervised labeled data, and it takes a more support vector machines they usually take a geometric approach. So it plots all the data points. So for example, we have probing depth, bleeding indices, and attachment loss in a three-dimensional or sometimes more, so a high-dimensional space. And what it does is it attempts to draw and we also label these. We say, okay, well, this has this probing depth, this has this thing, and these people have chronic periodontitis, and these people have acute periodontitis. And what the model does is it draws an optimal mathematical boundary, a hyperplane in 3, 4, 5 dimensions. And this boundary is drawn to maximize the distance between the stable and at risk, or between the acute and the chronic cases. So it's basically a classifier system. And so you can see how this model would excel when the diagnostic features are very explicit. There's a boundary between them. But if there's sort of a transitional phase where, it could be acute, it could be chronic, you're going to see these models sometimes stagger, and you're going to get false positives and false negatives on either side of this hyperplane. Now, we can try to solve the same problem with an artificial neural network. Now, an artificial neural network takes sort of a biologically inspired approach. And this is a semi-supervised method. So we have age and smoking, we have all the patient's data. And the model has access to all this data. And we still have it labeled as stable or acute and chronic. But an artificial neural network will pass all these information, all the patient's information, through one or more hidden layers of interconnected neurons. And it's going to continually adjust internal mathematical weights. And rather than drawing just a single boundary, it's going to learn the complex relationships hidden amongst the data, and it's going to calculate a final probability score of either acute or chronic. Now, an artificial neural network might realize, for example, that smoking is a multiplier. Okay, so it's going to increase the risk of chronic periodontitis by 4 times or 5 times. And so it gives it more weight. So now when you come and input new patient data and it sees, oh, well, this patient's a smoker, it's going to increase the probability that's going to say, well, this patient is more likely to be a chronic periodontitis case. And so you can see that in the end, you're going to press one button and it's going to give you, this is chronic, this is acute. But you can see how the difference in the weight of that diagnosis that the AI gives you, that a model gives you, in that this is just sort of support vector machines it's just a classification. Someone encoded their own classification into a model, while an artificial neural network actually digs and moves through the data and gives you sometimes pattern recognition that you couldn't see as a human. And this is a great example of using supervised and semi-supervised labeled data to solve the same exact problem. Now, the last network that we'll look at are generative adversarial networks, and these are very interesting. okay? And they're commonly used to denoise cone beam CT images for metal artifact reduction. And so for those of you that use CBCT in their office or order a lot of scans, we always want the highest possible resolution to see fine anatomical details. We want to see the PDL space, we want to see the canals, but we also have to adhere to ALARA. We don't want to unnecessarily irradiate patients. But when we lower the dose, that often means that we get more noise, more graininess in the scans. So a generative adversarial network is a framework that solves this by mathematically cleaning up these low-dose noisy images to look like a high-dose image. And so imagine you have two separate AI models, okay? So we have a generator and a discriminator. So the generator is like a dental radiology resident. His job is to take these grainy, low-dose CBCT scans and to paint over the noise, to reconstruct the image to make it look very clear. Now, this generator has seen what a high-quality image looks like, so structured data. And the discriminator is like, a master oral radiologist. His only job is to look at the scan and say, this is a real scan. This is an AI manipulated scan. That's it. And so, for example, the generator is going to denoise an image. So it's going to start cleaning up all the noise. But in doing so, it's going to blur the trabecular bone a little bit. And so it's going to send it to the discriminator, and the discriminator is going to look at it and say, no, this is an AI-generated scan. You can't just blur out the bone. So it's going to send it back to the generator. Now the generator learns, oh, I have to retain the anatomy of the trabecular bone. I can't just blur that while I'm removing the noise. And so during this process, the generator is going to get incredibly skilled at removing noise because they're going to do this millions and millions of times. The generator gets very good at removing noise, but preserving the anatomical structure. And the discriminator is going to get very strict at spotting even the tiniest little flaw and say, no, this is an AI-generated image. And so the model is going to keep on doing this until the generator gets so good at cleaning the noise that the discriminator can no longer tell the difference between an AI clean scan and a real dose scan. Now, a lot of people usually at this point ask me, well, how does it remove the noise? Or how does it clean it up? And they're very complex mathematical formulas of sort of applying all those different filters or convolutions that we said to accentuate certain features and hide certain features. And then they start subtracting the images from one another. So it's a very mathematically dense process. But these models are some of our bread and butter because without them, we really can't see a lot of things on our CBCTs. So we looked at some of the terminology that we utilize in AI. We looked at how we train models, machine learning, the types of data that we can feed into machine learning, some of the problems that we have in dentistry and the networks that we use to solve them. And so how do we deploy these networks? So let's take a look at some of the current uses of AI in dentistry. So they fall into four main quadrants. So we have diagnostic imaging, clinical documentation, treatment planning, and practice management operations. So with the diagnostic imaging, computer vision models act as a second pair of eyes to detect, highlight, quantify pathologies and bite wings, pans, CTs. Now, while radiologists rely on biological principles, clinical context to identify disease patterns, AI systems analyze by learning mathematical and statistical correlations, like we said. And this allows them to detect sometimes subvisual features that are imperceptible to us. Now, because these models don't really have general world knowledge, they don't really possess causal reasoning, they're prone to learning shortcuts, okay? So a model that we're trying to teach to learn how to detect periapical lesions might associate the presence, of gutta perca and say, well, if you have gutta perca, then you have apical periodontitis, rather than the actual periapical radiolucency. Or it might say, I'm going to associate that you have apical root resorption with orthodontic brackets. Because every time I see orthodontic brackets, or for the majority of the cases that I see orthodontic brackets, I see root resorption. And so it creates these these false associations. And so if there are no orthodontic brackets for the model, then there's no root resorption. And so we can see how we can start to get messy with the output of these models. Now, diagnostic imaging models are predominantly convolutional neural networks, and they require an immense amount of data to train. And so we're going to see why in a bit, and we'll talk about it. They suffer from a phenomenon known as the lab-to-field gap. And that's a significant decline from the training and then when it becomes deployed in real-world scenarios. And we have some of the market examples, PearlJet, Overjet, Videa Health. Those are some of the common ones available in Canada. Now, clinical documentation, I always expect it to be the most used because I know in clinic, I don't want to write notes at the end of the day. I just want to go home. And writing notes it's terrible. But clinical documentation can do, models can do so much for us. You have hands-free periodontal charting. We have automated soap notes. It's going to blur out your conversation with them about, their kid's chess tournament. And it's only going to bring in relative information. It's going to write it down for you. And you have your notes documented for you at the end of the day. I personally use it a lot, voice-activated radiology and pathology dictation. So I don't sit in a room and type. I'm sitting there holding a microphone, speaking to myself in a room like a crazy person, saying, well-defined periapical radiolucency around the mesial apex of 3.6. Saves me a lot of time, saves me a lot of hassle. I can write reports much quicker. Automated treatment plan and code generation. So as you're talking about treatment plans with your patient, you're saying, hey, you know what? You're going to have to take this tooth out. You can replace it with an implant. You can replace it with a bridge. You can replace it with a partial denture. Or you know what? You can do an endo, crown lengthening, a post, and a core, and a crown. It's going to automatically generate all those codes for you. So it's going to reduce a significant amount of administrative burden on your staff, allowing them to do other things, marketing, call patients, develop the relationships with patients. And so these tools are very valuable. And we have, Overjet has their own Overjet voice. There's Bola AI, a couple of examples in the Canadian market as well. Now, treatment planning models have been used for quite some time in dentistry, and not all of us can sort of detect them because they're embedded in software. So for ortho automatic self-tracing, that's something that we've been using for so long. Predictive treatment plan simulation, analyzing 3D scans, and then forecasting tooth movement, in pediatric cases, jaw growth. With Invisalign, automated aligner staging, softwares evaluate intraoral scans and calculate the safest and most efficient ways and sequence, way for tooth movement and sequence for aligners. Remote patient monitoring, these are, now patients can take pictures of their progress, their orthodontic progress with their phones, and then it sort of shows how they're doing, if they're actually wearing their aligners and such. In CAD/CAM, we have auto margin detection, automated restorative design, dynamic occlusion. When we're designing our crowns and it says, you're going to have a high occlusal spot here. You're going to have a very tight contact here. These are all AI models that are running predictive algorithms in the back and saying, last time someone did this came. They had an eccentric contact here. And so, real-time scan artifact removal when we're doing intraoral scans, and for those of you who use those, and the tongue gets in the way and then goes back out. You don't see the tongue in the scan. It recognizes that's the tongue. I'm going to remove it, and I'm going to continue adding my images to the scan. And so these help us immensely. We have practice management operations. So these are some of the tools that baffle me the most, to be honest. So I saw one recently that had a no-show prediction. So the machine learning algorithm would analyze the historical patient data. It looked at weather patterns and then the appointment types, and it would identify that this patient is a high risk of no-show. So it's going to be like, every single time it rains and Mark has a hygiene appointment, he's no-showed 90% of the times. So it's going to show you this is a high-risk no-show patient. So you're going to call that patient and be like, hey, Mark, it's raining today. Are you going to show up? And, 90% of the time, he's probably going to tell you, oh, no, I'm not going to show up. And you can just remove him from your schedule and book someone else in. Automated insurance verification and claims. I'm pretty sure most front desk and office managers are going to be very happy utilizing those tools. Predictive inventory management was one of the really cool ones. So it can go in and say, well, this month you've done 60 endos in this office. And the last time you ordered 75 sets of K files. So you should have 15 sets of K files left. You need to reorder. So these are all tools that can, remove burdens from office owners and ensure smooth operations within the office. And yeah, this has enormous revenue potential for clinics if utilized properly. And some of these, Pearl and Overjet are the two big ones in Canada, and Oryx is really an up-and-coming one. And so, you go to a conference and a sales rep comes up to you and says, you know what, we have this new AI model, or even your existing, clinic software, and they say, hey, you know what, we're deploying this new AI model. You're grandfathered in, you're going to get it. How do you know if, should I use this? Should I not use this? How reliable is this? They're going to present you with a paper, a research paper. They're going to give it to you. You're going to go home. You're going to read it. You're going to be like, okay, should I use this or not? So let's take a look at some of the few things that we should be aware of when we come to look at new models. So like Mom said, you are what you eat. And that translates to algorithms as well. An algorithm is only as good as the data you feed it. They don't have innate medical knowledge. They don't have causal reasoning. It's entirely dependent on the data that you feed it. So if you feed it good data, you're going to get a great model. If you're going to feed it bad data, you're going to get bad data. You're going to get a bad model. And with AI models, we have two major hurdles that come up. We have the lab to field gap and the black box phenomenon. And those are the two that we should be aware of and why they show up. So the lab to field gap we define as it's a drop in performance when a model moves from the lab into a clinical environment. Okay, so when we look at the model in the lab, it's mathematically perfect. You're going to see these numbers. It's going to say 99% detection rate, 99% accuracy, 89% accuracy, whatever it is. But then when it moves into the real world, you start to deploy it in your office, all of a sudden it goes down to like 40 and 30. And so there are several reasons why this might happen. And these are the things that we need to be aware of. So let's take a look at selection bias. Okay, so this directly fuels the lab to field gap, where a model that's going to achieve near perfect accuracy in a controlled testing environment suddenly is going to struggle with real world data. So let's take a look at an example. Okay, so we have a Toronto software developer based in Toronto that's going to develop a model, same example, to detect interproximal decay on bite wings. And so, they come and present you a paper. We have, 200,000 bite wings. Wow, impressive data set. That's one of the first things everybody looks at. Oh, you have 200,000 bite wings. That's a huge amount of data set. But then you ask them, it's like, well, where'd you get this data from? And they tell you, oh, well, we got it from 2 offices on the bridle path. It's like, oh, okay. So very wealthy people. They probably go to the dentist every 6 months and get their cleanings and get their bite wings. For argument's sake, let's say, oh, they have fluoridated water. And so what the model is going to do is it's going to look at these x-rays and it's going to find like little tiny triangles, interproximal. But, it's going to say, oh, that's a cavity, that's a cavity. And it's going to see this bombed out tooth and it's going to be like, I don't know what that is. That could be cancer, but that's not a cavity. That's not the cavity I know. I know what a cavity looks like. And so you quickly see how the models become very biased based off of the population that you're going to send them. And so it's very important to have a global, a very diverse data set. Now, this means people of all income, people of different geographical locations, people of different races. It's going to mean, you need to give it bite wings with cone cuts because your assistants take cone cuts. It's going to mean you need to give it underexposed and overexposed bite wings, overangulated and underangulated. All these are feed into the diversity of the data set to really improve the overall performance. But if you're giving it perfect bite wings, and then you sort of give it an imperfect bite wing that's angulated with a cone cut, and you're telling it, hey, is there any decay here? It's going to struggle, or it's going to give you lots of false positives and false negatives. And so selection of our data is one of the most important things. And it's something that we need to sort of really dig into and ask more questions about it to understand that we don't get that significant lab to field gap. Now, labeling bias is another direct contributor to the lab to field gap. And this arises when we use structured labeled data. So the human annotations used to train AI models a lot of times are inherently subjective and inconsistent. You have to remember that different specialists are going to disagree on the boundaries of pathology. If you ask a pathologist and an oral surgeon, where are the boundaries of this ameloblastoma, they're not going to draw the same boundaries. Okay, just like dentists, just like as a general dentist, you might disagree with your peer on what's the best treatment for a patient. And an algorithm only learns to replicate the specific quirks of the annotator rather than objective clinical truth, because it's just a mathematical pattern. And so in doing so, it creates that lab to field gap when these models are deployed across a diverse clinical field. And so if a pathologist is the one drawing the boundaries, and then it goes to an oral surgeon, he's like, well, this model is completely incorrect. That's not where I would cut. I would cut in a completely different location. And think of if you're getting data that's labeled by 3 dentists. Okay, usually if you look at a study, it'll tell you the gold standard. An oral maxillofacial radiologist annotated this data. Okay, was it 1 or was it 3? And were the 3 from the same school? Oh, you had 5. Were the 5 from the same continent and the same educational system? Or do you have people from Africa and Asia and Latin America? The more diverse we get in labeling, the more diverse or the more opinions that are being ingrained into the model. And so this is something to look out for when reviewing a paper, and ensure that the clinical background of the annotators is very diverse, because that means that you're going to have a very robust algorithm. And if you just have, if it just says the gold standard and it's 1 or 2 radiologists, yeah, sure, you proved something, but this isn't a model to be deployed clinically. And then we have, and this is for convolutional neural networks, the type of data that we're doing. Most image models or radiographic models are trained on clean data with minimal noise. And then when they're deployed, they see this, they see streak artifacts, beam hardening, cupping, streaking, and they don't know what to do with it. Or sometimes what we do is, and when we train data, we actually give it this data, but then we apply one of those GANs, those despeckling, denoising filters, before the input phase of that convolutional neural network. And you might say, okay, well, that's wonderful. Why can't we do that? Why can't we apply that? And then the model is going to tell us or do its job and figure out what it's trying to detect. And these GANs are run on supercomputers. That little tiny mini Dell PC that you have in the operatory, if you press a button and it's going to run a GAN, and then it's going to run one of those convolutional neural networks, yeah, before you get your prediction, it's going to probably be a couple of hours if the computer makes it through those hours. And so this leads models to struggle to identify noise that it hasn't seen before, and that leads to incorrect labeling. And so these really hinder the performance of these models. And so when you see that, we have that 98% detection rate, take that with a grain of salt. You need to do a little bit more digging to figure that out. And these are all FDA approved models. Now let's move to the black box. Now, this is a very interesting and concept, and not a lot of people sort of are aware of it, but the interpretability of and the black box problem is that many machine learning models, especially neural networks, they operate as a black box. And what that means is that they calculate the output, but then they don't explain the medical logic behind that. And that lack of transparency sort of can disrupt your trust in the tool. Because if I don't know why you chose something, then I don't know when you might fail. I don't know when you might give me an incorrect prediction. Now, newer models sort of try to fix this by using heat maps, okay? And this highlights exactly which pixels or data points led to that specific prediction or that specific output. So if a model comes and says, well, there's apical root resorption, and then it highlights, the pixels around the root, you're like, wonderful. But if it tells you, what, there's apical root resorption, and then it highlights the orthodontic brackets, you're like, well, this model has a problem. Okay. Now, the majority of models are black box models. And so if they don't have these heat maps, it might be giving you a very accurate output and saying, you know what, yeah, I have 79 or an 80% output. But it's really getting its decision making from something that's completely incorrect. The correlations that it's making are not proper. And so heat maps are starting to solve this. And there's several other ways that models are becoming more explainable. And so, you go and you get that paper from your sales rep, and you're going to start looking at it. And you want to vet the software. You're like, I want to know if this is good. So, what do you look for? So like we said, a model might perform perfectly on the specific data it was trained on, but fail when it's used on a new population. And so to ensure that it's safe for general patient care, you have to ask, was this tested on external data? And you'll usually see in papers, they'll say, oh, we had a data set, and they usually divide it 80% for training and 20% for testing. But they never tell you where they got this data set from. And so if you got the 80%, from the bridle path, did you test it on 20%, from Mississauga or from, Italy or from Asia? You have to test it on that global population to know that this is going to, especially in Canada, we're a very diverse population. You need to know that it's going to perform equally on all your patients, not a specific cohort of your patients. Just like clinical trials, AI research needs strict standards. A good model has to clearly report large sample sizes, blinding procedures, use quality assessment tools, to evaluate the risk of bias. So demand a methodological rigor from those studies. Read those papers and make sure that they went through the process to actually do this properly. And prioritize clinical value over mathematical accuracy. A model can have that 99% mathematical accuracy, but still be useless in a clinic. For patient care, it has to be user-friendly, unbiased, has to be explainable, provide visual explanations like heat maps or other explanations. And so as a dentist, you can verify why this AI made its decision. And so if you're going to, as a clinic owner, adopt and say, okay, you know what? I read the paper. I really like this. I want to adopt it. So let's assume you're going to adopt one of these note-taking AI models. So what are you going to do? Are you just going to deploy it in your office? Does the patient have a right to know that you're using it? So be very careful when we do this. Patients have a right to know. So if you're going to be using one of these note-taking, explain to the patient, explain that you're using an AI tool. Hey, we're using an AI tool to take notes. This is going to ensure that everything that we discuss is written down. But explain its limitations. Be like, oh, you know what? Sometimes it misses stuff. So we always double check, the notes, and before we give you a copy of them, of the treatment plan. So if you see something that's missed in there, hey, please let us know. AI isn't always perfect. Get consent. Now, it doesn't have to be a written, consent form, but at least have verbal consent. Tell them, hey, I'm using this. Document the process, because they might have questions for you. They might say, hey, well, we're talking about personal health information. Where's this data stored? Is it stored on your computer? Does it go on a cloud? Can it be hacked? Be prepared to answer those questions. Because if you can't, you're going to shake the faith of your patient in the tools that you're choosing. And, we're always going to get that one patient that sits in a tanning bed for 15 hours a week and is going to come and it's going to be like, I don't want to take a bite wing, I'm afraid of cancer. So provide manual opt-outs. The patient's going to tell you, hey, I don't want to use that. I don't want to use a an AI note taker. Provide that opt-out, tell your assistant, get out that bench paper and pen, write everything down. You're going to stuff it in your scrubs, and we're going to write notes at the end of the day, the good old-fashioned way. Okay. And then personal word of advice, avoid automation bias. That's the biggest trap of AI. Like I said, I sit here in my room. I have my microphone. I sit there. I say, well-defined corticated radiolucency at the mesial apex of 3.6. And then I press a button, and that button will give me my impression. And it'll say, periapical cyst 4.6. That's like, I just said 3.6. So it makes errors. Okay. It's not perfect, but it's going to reduce your workload significantly. So the least we can do is just double check it. Make sure that everything is going right. We're already winning that we're not doing, 50, 60, 70% of the work. And this ties back into that augmented intelligence mentality. It's there to assist you. It's not here to replace you. And, unless we reach to artificial general intelligence soon, at that point, we'll all be out of work. So you don't have to worry about anything at that point. But as long as we're in that narrow intelligence domain, it's not going to replace you. Okay. So after talking about this, after understanding how these models work, what goes into building them, how many of you are confident or are interested? You have a new interest. It's like, oh, I didn't know that these applications would work. Chris, I'll give that to you.
Yeah, so we have another poll question here. Hopefully, after your comments, people may have developed a little bit more comfort around AI and how it can be used. So this final question is really just trying to capture that sentiment. So we'll give people a couple more seconds. And so it would seem that the top answer is, I would use one or more of these AI models, 45%.
Yeah, I think that's great. AI is definitely here to help us. It definitely can aid us in decreasing our workload and freeing up our time to be able to do other things, as long as we're, aware of where its setbacks are. And that brings me to our last slide, which is something lots of people like to talk about, but it is a very vague area, and that's liability. And so in the dental AI world, it hasn't been around for so long that we've had mishaps and lawsuits to set precedents. And so we get the majority of our rules sort of from the medical world. And currently in the medical world, the doctor bears the primary risk. If, an AI model tells you, hey, you should take a biopsy of this lesion, and you go in and take a biopsy, and it turns out to be a vascular lesion, and that patient bleeds, that's on you, 100%. At the current time, there is no excuse for it. But what we're also seeing is, oh, you missed a lesion. Did you not have an AI model in your office to be able to detect this lesion? Did you not consult it? And so we're starting to see the narrative shift in that everyone is utilizing this AI narrative to their own benefit. We've seen hospital liabilities. We've seen, and in this place, like for us, it would be a clinic liability. If you're going to adopt this new AI model, and you're not going to train your associates on how to use it, your associate does something wrong, he's going to be like, well, no one trained me. No one told me how to use this AI model. No one told me its accuracy. And so I don't know. If you're not doing performance audits, going in and saying, well, oh, this actually is not a cavity. It got one wrong. And you're doing that and you're sending it back to the developer. So maybe your clinic might become liable. And then we're also now seeing cases of developer liability, where hospitals were actually doing their performance audits and are going and suing these developers and saying, well, you gave us this, an 80% accuracy rate. We're doing performance audits. That's 20% accuracy rates. But developers are very difficult to sue. And I was just talking with Chris about this a couple of days ago. There's a large group of the largest medical imaging software developers in the US, and they just requested from the FDA, I think in December 2025, and it's going to get voted on sometime in March or April, of exemption from any life-threatening conditions that are missed via their softwares. And the reasoning is, well, we don't have patient history, we don't have context, the algorithm doesn't have any of that. And so the physician's ultimately liable. And so we're going to see the narrative shift over the next decade, and we're going to see how this plays out. And we just have to look at sort of the ethical uses of AI. Who's using it and for what purpose? Are insurance companies creating their own models with bias data to deny claims? Oh no, my AI model says that you can put a bridge here. You don't need an implant. Sorry, we're not going to approve that. Or maybe to suggest cheaper treatment alternatives. Are large, huge corporations and offices using it to push treatment on patients, saying, "Hey, the AI requested it." Or even on their associate dentists, young new dentist wants a full schedule. Oh, you know what? The AI is filling your schedule. Oh, are you rejecting the AI's treatment? Oh, well, we gave you a full schedule, so sorry. Now you have an empty schedule. That's your own doing. So needless to say, there need to be guidelines that govern creation and the utilization of AI models. And this really emphasizes that need for that augmented intelligence mentality. So do not rely on AI. Don't let your skills become blunt. Keep them honed, and embrace the idea that this is here to help me. It's not here to replace me. I still have to be on my A game at all times, but I'm going to have a lot more free time because this is going to help me. And yeah, that's the end of my presentation. Thank you so much.
Yeah, that's fantastic. Thank you so much. It seems to me that there's a lot of opportunities and efficiencies that AI can bring to dental practice, but it also means that there's some degree of caution warranted, and as you pointed out right here at the end, that some degree of clinical judgment is still needed.
Yeah, I think it's going to be, we're going to see AI is here to stay. It's not going anywhere. It's going to continue to help us develop and help us, grow as dentists. And if we can divert our attention from, little tiny tasks like writing notes every single day or doing this or doing that, we have more free time that we can invest in becoming better care providers.
That's right. That's right. It is here to stay, isn't it?
Yeah.
So I just want to mention that we are at the 1 hour mark for our presentation, but we are going to entertain questions for those that have any. So our guests are more than welcome to stick around while we go through a Q&A. So if you do have questions, a reminder to post them to the Q&A section on the bottom of the screen. In the meantime, I wanted to pick up on the last slide that you talked about, Dr. Ahmed. It's kind of ironic, isn't it, that when we started the presentation tonight, the result was 65% of dentists aren't using AI in their practice. And yet, when we talk about liability issues or potential liability, the questions are now being asked, are you using AI at all? As though there's credibility and that it should be relied upon in some cases. That may motivate people now to start implementing it more often in their practice.
Yeah, and I think it's a fair question, because if you embrace the idea that it's there to help you, assist you, rather than saying, "Oh no, I'm not going to use this tool." Some people fear it. Some people don't want change. Some people fear it might replace them. It's fair to say, well, you had a tool at your disposal that is more superior than you in detecting specific things, and you chose to ignore it as a healthcare provider. So in that action of ignoring it, you didn't prioritize the patient, you prioritized your ego. And so it's a fair question to ask, but we're going to see how this narrative plays out, because, thankfully, we're about a decade behind the medical field. So they're going to see the brunt of that. They're going to see all the lawsuits, and we're going to learn from them. And hopefully we can sort of adjust for our own specialty and say, hey, you know what? These are the limitations that we're going to put on this, because we're already seeing abuse of AI models with medical insurance in the US. we've already seen cases and incidences like this that have gone to court, and so let's hope we play it out in a much more civilized manner.
So, as you said earlier, too, AI is here to stay. So, what do you think are some of the obstacles or concerns people have, or what can they do to overcome some of these obstacles to start embracing it and using it more often in their practices? Is it just a matter of education, or is it more than that?
I think it's um, I think it's a combination. I think as humans, usually when we're bombarded with so many options, we tend to get skeptical. And so when you see all these AI models coming out every single week, every single show I go to, someone's telling me, "Oh, I have a new model that does this prediction accuracy 100%." Well, you can't all have models that are prediction accuracy 99%. And even if you do, there's something wrong because you know and so I think it's a matter of education, of understanding how these models work, just being able to sort of critically evaluate. And just like anything, there are brilliant models out there, models that'll help us and save us time. And so it's just having that capacity to be able to differentiate the good ones from all the background noise. And I think once people get comfortable with AI, they've been around for a while, they see that, it's really going to take off. We are still in the early stages of it in the dental world. And so I think within the next 5 years, we're going to see a significant ramp up in AI utilization.
I have a question here from one guest, and it says, I compared my identification of caries in a series of bite wings against overjet product. It seems caries detection is useful for those cases where there is decay that may be in question and requires human probing. Doesn't this limit the value of the AI tool in caries detection?
Yes, I would say yes, it does in that specific circumstance. But a lot of times you're going to have, for example, a bite wing that's not really a great bite wing. And as a human, we might miss it because it's underexposed. We're going to take a look and we're going to say, you know what, I don't think there's anything there. And that happens a lot of times to me. You're looking under an amalgam and you're like, is that something? Is that not something? You know what? I'm going to watch it. But now instead of watching it, you can say, well, let me get a second opinion. And so this is where it goes back to that, what I was saying, that clinical value over mathematical accuracy. You're going to have a lot of models that are going to give you that mathematical accuracy and say, oh, we have this much detection. But when it gets deployed, you're going to quickly realize that it doesn't give you that. That's sort of an illusion. That's in its isolated little field, it can give you those numbers. And when you deploy it in your office, you're going to say, oh, well, actually, I need to take a look at this. I don't really trust this. And that's good because like whoever put that question, that means that they're double checking the AI. And that's the whole point, to utilize it as a tool. The point isn't to click the button and say, oh, well, I have this guy has 5 cavities. Let's drill. The goal is to question it. Yes, it's just an assistive tool. It's not there to do it for you.
Yeah, it seems the pairing of professional judgment and AI tools seems to be where things would be going.
And we're going to find that sweet spot. I think most practitioners are some are going to rely on it significantly in the beginning. Some are going to be very cautious, and eventually, as models become more accurate, we're going to reach that sweet spot where people know, okay, this is how much we can trust it.
I have a kind of a technical question related to this and concerns of privacy. Are you aware of any guidelines from the college or any other guidelines that says that data captured by these systems have to remain within Canadian servers?
So the RTDSO, I think, just said that all AI models have to be PIPEDA compliant. And so if they are PIPEDA compliant, that means that, yes, the data has to stay. I'm not sure if it's Canada or North America, because I know some North Americans are like Amazon, like a lot of people use Amazon Web Services. That, they have servers in Canada, but their servers are interlinked. So sometimes they'll store stuff in the US. But for the most part, I think the majority of that data is secure. And a lot of algorithms run native. on a local system. So they're not it's not really sending data anywhere.
Right. Okay. All right. We have another question here. Is software like Pearl or Overjet getting approval from FDA as diagnostic assistance or as definitive detection devices? And has Health Canada approved any software for caries detection?
So for the majority of softwares that we have in Canada, they first go through FDA. Because once something goes through FDA, it's easier to approach Health Canada. In Canada, we're very tight. We're very restrictive about everything. And so when Health Canada sees something has gone through the whole FDA cycle, it takes it and then it starts adding its own components to it. All like medical imaging AI models are classified as assistive devices. None of them are definitive, because no developer is going to take on that risk and say this is definitive. Because if they say it's definitive and they get one wrong, you're done for. So they're going to say it's assistive. And for the majority part, it is assistive. But a lot of times, you're going to get very good value out of it. It's going to be a great tool in those cases where you have doubts about something. And we have a lot of doubts in clinic. You know, a lot of times, like as a radiologist, a lot of times I get scans and requests that I'm just like, well, you know, for an antral pseudocyst and a sinus, they're like, what is this? Should I be worried about this? That burdens me, because if I have 3 or 4 of those cases a day, that takes away from my time. Because after those 3 or 4 cases, I look and there's a huge lesion taking off, you know, half a mandible. I should have been focused on that, not all those antral pseudocysts. I still have to sit there and dictate, you know, the whole report. AI is wonderful, and you click that, and it's like, oh, that's nothing to worry about. It's going to get that right a lot of the time. Those, you know, those things that are, you know, clinicians have questions about. Not everyone knows. Someone forgot about it. But when you get to cancers and stuff like that, yeah, you don't rely on it. Definitely don't put your license on the line for a software that someone else developed. No. So I would treat them always as assistive tools, never as definitive.
Excellent. Excellent. Thanks for the clarification.
Yeah.
Well, that seems to be all the questions that we have right now. So I'd like to
Wonderful.
wrap things up this evening. And thank you very much. I mean, we really do appreciate you sharing your knowledge.
Thanks for having me. Yeah, it's a topic I really enjoy talking about. So thanks for allowing me to chat.
Well, look, AI is advancing, right, at this incredible pace, and the innovation is going to continue. So it's important to stay informed about how the industry is changing.
For
I'd like
sure.
to close by saying that if anyone has further questions for Dr. Ahmed, or even would like to receive a copy of the presentation, you can feel free to contact him directly by email or send the email to info@starlingrad.com. I'd also like to remind our guests that TMFD Financial specializes with dentists and understands the challenges you face on a regular basis. So whether it's tax and accounting, business issues, or personal financial planning, we're here to help coordinate and simplify your affairs. So feel free to contact us at info@tmfd.ca. So I would like to thank you for joining us this evening. In the days following, a video of this will be posted onto our website, tmfd.ca. You'll also receive a brief survey asking how you enjoyed tonight's presentation, so you can share your feedback. And please do tell your colleagues about TMFD Dental Academy, and we'd love to have them join us and gain from this collective knowledge. A reminder that the CE credits will be issued in the next couple of weeks. And finally, I wanted to mention that TMFD will be at the ASM this year, so please drop by our booth to say hello or come by and hug an accountant. You know, it's tax time. We need the hugs right now. And also, please note, TMFD will be hosting additional webinars later this year, so please stay attuned to those announcements. And as we close up, I'd like to thank our speaker, Dr. Ahmed, for his expertise and insight tonight. And thank you to all of our guests. We appreciate you being here. Thank you so much and enjoy the rest of the evening.
Thank you so much.